Welcome back to the Great Adventure, Pediatric Pulmonary Physiology. This is the 23rd presentation in a series of 30. We're going to be talking about the effects of sleep on breathing. This is number 2. This is the Great Adventure, Pediatric Pulmonary Physiology. And as you can see, we're moving along here. We want to approach this with the enthusiasm of a kid in a candy shop. And I want to remind you again about the respiratory balance. Remember, the respiratory system is not just the lungs, but in order to have adequate ventilation, you must have adequate central drive and ventilatory muscle power to overcome the respiratory load. Now, we talked last time about that sleep decreases central drive compared to wakefulness, which can put this balance in a precarious position in some situations. And remember also that we talked about the fact that nobody breathes as well while asleep as they do while awake. So respiratory disorders often present first during sleep. Today we're going to talk about hypoxia in infants during sleep, the chest wall during sleep, the upper airway during sleep, and the upper airway during positive pressure ventilation while asleep, something that many do not think about. So this was done as part of the CHIME study, which you learned about last time. And what we did was to report the oxygen saturation in the healthy term infants during this study. And remember that this was a study where healthy term infants were monitored from birth to about 6 months of age or 24 weeks. So this plots the 50th percentile, for example, for average oxygen saturation during sleep. And you can see, not surprisingly, that it runs at about 98% saturation. The 5th percentile, however, is down here in some cases at around 94th percentile, which is a little lower than some people might think. So this is normative data. This plots the number of seconds of desaturation defined as less than 90% oxygen saturation during sleep, again, versus age. And you can see that, first of all, we're talking about seconds. So this is not a lot of time, but you can see it's more common in the first, let's say, month and a half or so, 6 weeks, and less common as the infant ages in the first 6 months of life. Overall, the study showed that the average baseline oxygen saturation was about 98%, and it did not change with age. Hypoxia, that was defined as an oxygen saturation less than 90%, occurred in 59% of infants, and it occurred about 0.6% of the time, or more strictly speaking, in 0.6% of epochs. Acute desaturation were most common in periodic breathing or short apneas. How well do sick babies control their oxygenation during sleep? So, Mina Garg and Sharon Isanaka were fellows in neonatal perinatal medicine here at Children's Hospital of Los Angeles, 1985 to 87. And they did a study where they looked at hypoxia during sleep and feeding in babies with bronchopulmonary dysplasia, babies who had respiratory distress syndrome, that is, they were premature, but did not develop chronic lung disease, and in healthy term control infants. And you can see the numbers here, 14 BPD, 15 RDS, 8 controls. Post-conceptual age at study was actually similar, a little bit less in the RDS babies, but 41, 42 weeks. Birth weight, obviously less in the preterm infants. This study was performed in 1988, so these birth weights are a little higher than you might see. Weight at the study, however, except for the controls, was comparable. And the days of supplemental action for BPD was 54, 6 for RDS, obviously none for controls. And the days of mechanical ventilation in the newborn period, 49 days for BPD and almost 5 days for RDS. This shows the duration of oxygen saturation less than 90% as percent of sleep time. So the BPD babies spent 16% of their time during feeding hypoxic. RDS, only about 4%, controls, of course, none. During wakefulness, about 6%. So a normal blood gas, I'm going to suggest to you, does not give you confidence that somebody is normoxic all the time. about 4% during active sleep, 1% in quiet sleep, 2.5% in total sleep, and 7% in total time. The practice at the time this study was done was that blood gases were done to assess gas exchange. Now, blood gases, by definition, are done during wakefulness. And so it was assumed that if somebody had a normal blood gas, they had normal oxygenation. And what this study really showed for the first time is that feeding, which is about the most exercise a baby does, and sleep were in fact associated with hypoxia. This shows duration of saturation at less than 80%. And you can see again the BPD baby is about 4% of feeding time, about 1% of active sleep, and wakefulness, 0.5% of total sleep time, and 2% of total time. So again, a normal blood gas during wakefulness does not mean that somebody is not hypoxic at other times, for example, during sleep or feeding. This was the duration of saturation less than 90% for the control infants, and therefore we developed a normal range of less than 1.1% during feeding, less than 1.1% while awake, less than 0.4 during active sleep, less than 0.1 during quiet sleep, less than 0.2 in total sleep, and less than 0.5 totally. A number of these babies at the time also had pneumograms performed. Pneumograms were tests of ventilatory pattern using chest wall impedance pneumography and electrocardiogram. All right, this was commonly done at the time because infant home monitoring was a common clinical practice, and it was used on preterm infants that had abnormal pneumograms. So these babies did sleep adequately. Longest apnea was comparable between the two groups, around 8 to 9 seconds. Apnea density, that is, the time spent in apnea as a percent of total sleep time, was actually higher in the RDS groups, interestingly. Periodic breathing as a percent of total sleep time, again, higher in the RDS group. Sustained bradycardia less than 80, number of events low, and abnormal pneumograms was really about the same between the two groups. If we look at infants with abnormal oxygen desaturation in either the BPD or the RDS groups, there was actually no significant difference whether they had a normal or abnormal pneumogram, meaning that lower oxygen saturation did not correlate with an abnormal ventilatory pattern. Hypoxia during sleep and feeding also did not correlate with dynamic pulmonary compliance. You can see here the percent of time at saturation less than 90% plotted here, and the dynamic compliance. There was no statistical relationship here. There was, however, a statistically significant relationship between airway resistance. That is, those babies who were hypoxic during sleep and feeding, who were more hypoxic, had a higher resistance. Remember, high is bad for resistance. So clinically unsuspected hypoxia occurs frequently in preterm infants with and without BPD during sleep and feeding. Hypoxia did not correlate with ventilatory patterns, but it did correlate with increased airway resistance, suggesting that the severity of disease had some relationship to this. So how well do BPD babies cope with hypoxia? So again, Doctors Garg and Isanaka did a study where they took 12 infants with BPD and they performed 16 hypoxic challenges on them while they were asleep. The estimated gestational age at birth was 29 weeks. The post-conceptional age at study was 41 weeks, so they were actually term at this point in time. The birth weight was 1.2 kilos. The weight at study was 2.4 kilos. And as neonates, they had spent almost 50 days requiring supplemental oxygen and 43 days requiring mechanical ventilation. So the way this study was done was infants were placed under a head hood, which at the time used to be used to give supplemental oxygen, but we introduced nitrogen to reduce the fraction of inspired oxygen to 11%. This is roughly the equivalent of breathing at 10,000 feet elevation. So it's not something that we thought was harmful, but it is something that an infant should note as being different than breathing 21%. This shows a hypoxic arousal response test. So what is shown here is arterial oxygen saturation, What's shown here is end-tidal oxygen. Both are falling because we're decreasing the oxygen to 11% when we start the study. This is heart rate, shown here. Slight increase with hypoxia, which would be normal. This is the pulse oximeter tracing. This is respiratory effort, and this is an electrooculogram. All right. So this is the start of the study, and you can see that oxygenation does fall to a bit below 80% saturation. There is perhaps a slight increase in respiratory effort as a ventilatory response to hypoxia. In this particular case, this infant does not arouse after 3 minutes, which was the duration of the study, and so the infant was returned to room air. This would be a failure of arousal. This infant did appear to have some ventilatory response to hypoxia, but did not wake up in response to this hypoxic challenge. This is the sleep prior to baseline sleep prior to the hypoxic challenge. Time, as you can see, varied. Heart rate was in a normal range. Respiratory pattern perhaps slightly increased. A transcutaneous O2 was 51, saturation 96%, and the number of infants who spent abnormal time, that is with a SAT less than 90%, was 42%. 92% of the infants aroused to hypoxia. Nearly all of them aroused to the hypoxia. That was good news. This is the P-inspired O2 at hypoxic arousal, so it's about 78. This was the arterial oxygen saturation at hypoxic arousal, which was about 60. And this was the decrease in PCO2, which occurred indicating a ventilatory response, was about 7.2 millimeters of mercury. So arousal occurred, fairly low oxygen here, but there was a ventilatory response. However, at the end of the hypoxic response, 92% of the infants, although they aroused, required vigorous stimulation and some oxygen. 2/3 had prolonged apnea and bradycardia, and 1/3 required brief bag to mask ventilation. Obviously, when these results became available in the first 12 infants, we discontinued the study. But this shows that these babies do not tolerate hypoxia. So they have spontaneous hypoxia on the one hand, but don't tolerate it on the other. Again, these babies had pneumograms, as you can see. Longest apnea here, 8 seconds on average, apnea density 0.1, periodic breathing 0.3, the sustained bradycardia number of events 1.4, and the number who had an abnormal pneumogram were 44%. But infants with prolonged apnea and bradycardia, there was in fact no difference whether the pneumogram was normal or abnormal. Not statistically different, let's put it that way. So 80% of infants, even with a normal pneumogram, had this prolonged apnea and bradycardia post-hypoxic. So infants with BPD generally arouse in response to hypoxia, but after arousal they have apneas, bradycardias, and requirement for stimulation, oxygen, and brief ventilatory support. This is not related to their ventilatory pattern, and therefore they do not respond well to spontaneous hypoxia that occurs. All right, let's talk about the chest wall during sleep. So recall that in infants, okay, REM sleep is a significant portion of sleep time. About 18 to 20% of sleep time in adults is in REM. And in childhood, even 2 to 3 years of age, it's about 23% of time. So REM is increased in childhood. This is a brief lesson in neurology. All right. So for any neurologic process, there is a central sensory input. All right. This goes to some sort of integrator that basically correlates CNS activity, and then the output here is some motor activity. In non-REM sleep, or quiet sleep, this same pathway is true, but the robustness of the connection between sensory input and the integrator and integrator to motor output is decreased. In REM sleep, the robustness of this connection is considerably decreased. And in fact, in REM sleep, remember, there is a generalized neuromuscular blockade except for the diaphragm and the extraocular muscles. All of these responses are going to be less rigorous or less robust in REM, a bit greater in non-REM, and most in wakefulness. When you're awake, your respiratory center sends a message via the phrenic nerve to your diaphragm for your diaphragm to contract. Now, it also sends messages to your intercostal muscles for them to contract because you don't want your rib cage to distort inward. So the intercostal muscles contract synchronously with the diaphragm to prevent inward distortion of the rib cage. We'll talk about this a little bit later. In non-REM sleep, the same occurs, but these signals to the intercostal muscles are not as robust as they were during wakefulness. And during REM sleep, these signals are indeed significantly weakened. In REM sleep, here's what happens. When the diaphragm contracts, remember that it increases intra-abdominal pressure, decreases intrathoracic pressure. But because you have contraction of intercostal muscles, which stiffen the rib cage, there is no inward distortion of the rib cage. During REM sleep, however, intercostal muscle tone is knocked out. And therefore, when you have diaphragm contraction, negative intrathoracic pressure, this tends to suck in the rib cage instead of fresh air. Now, this is something that obviously is seen in newborn infants, especially preterm infants. One, because they spend so much time in REM sleep, and two, because their rib cage is not ossified. But this is also seen in adults. So when I was a postdoctoral fellow in Toronto, it was a tradition that we were subjects on each of our fellow colleagues' studies. So I was, in fact, a subject in this study, which looked at inward distortion of the rib cage during REM sleep. And even somebody like me with pretty bony ribs and thick intercostal muscles, during REM sleep, I showed inward distortion of my rib cage during REM sleep. So this is a tracing in a preterm infant during REM sleep, and you can see that when the diaphragm contracts outward most of the abdomen, the rib cage distorts inward on every breath. What's the consequence of this? One might add, so what? So here we have, again, a newborn infant during quiet sleep. In this case, the chest wall does not distort inward, and that's because there is a synchronous contraction of intercostal muscles with each breath that stiffens that rib cage and prevents inward distortion. Now, during REM sleep, you can see that there's absent synchronous contraction of the intercostal muscles. Consequently, there's inward distortion of the rib cage. Now, the baby has two choices. The baby can either accept decreased ventilation because that baby distorted the rib cage inward as opposed to sucking in fresh air, or he can try to compensate for that by increasing breathing, as you see the baby has done here. Increased abdominal contraction and increased EMG. So REM sleep is associated with increased work of breathing. REM sleep is associated with increased work of breathing. And it's because largely of basically a highly compliant or kind of floppy rib cage that distorts inward because there is no synchronous intercostal muscle contraction. In infants during REM sleep, chest wall stability is decreased due to cartilaginous ribs. Intercostal muscles contract synchronously with inspiration, stabilizing the chest wall, but this is absent during REM sleep. So inward distortion of the rib cage during REM increases work of breathing. So how well can infants handle this increased work of breathing during REM? Remember that infants have decreased diaphragm strength compared to older children and adults. We discussed that earlier. Infants have decreased diaphragm endurance compared to older children or adults, and therefore they are at increased risk for diaphragm fatigue. Now, this was the study we discussed when we considered ventilatory muscles by Harris Russos and Peter Macklin at the Meekins Christie Laboratory at McGill. And recall that what they did was take, in this case, adults, had them breathe through an inspiratory resistance so they could set a target transdiaphragmatic pressure that they needed to generate on each breath as a certain percent of PDI max. And recall that they showed that fatigue occurs if the transdiaphragmatic pressure, PDI, you generate is greater than or equal to 40% of your max PDI. This plot shows that the length of time that subjects could sustain or generate a diaphragm pressure on each breath over the max PDI. So obviously, if somebody had to breathe against a very high or generate very high PDI, they can only do it for a short period of time. And basically, they could sustain about 40% indefinitely, meaning that if you have to breathe against the PDI, which is greater than 40% of your max, you will fatigue. It has been shown that in skeletal muscle, if it's fatiguing, and if you do a power spectrum um, analysis on the EMG muscle, that with fatigue, you get an increase in power in the low frequency, a decrease in power in the high frequency, or the high to low ratio decreases with fatigue. Dietze Gross at the Meekins Christie laboratory repeated the studies of Russos and Macklin, but in this case, she was monitoring the diaphragm with surface electrodes. Well, in this case, esophageal electrodes, but subsequently showed that you could do it with surface electrodes. So same experimental design, right? We're going to use an instory resistance to have the subject breathe against different PDI values as a percent of PDI max. But now she's also going to measure the high-low ratio. And here's what she found. In a subject here, for example, if the PDI that somebody was breathing against was only 25% of PDI max, remember these individuals should not fatigue, and you can see the high-low ratio was sustained. At 50% PDI max, these subjects should fatigue, and you can see that there was a fall. And at 75% PDI max, they should fatigue even more, and there was a fall. These are the group data. Again, no fatigue, no change in high-low ratio. Moderate fatigue, fall in high-low ratio, and severe fatigue, a significant fall in high-low ratio. This shows that surface EMGs can be used at the high-low ratio, the power spectrum analysis can be used to detect fatigue of the diaphragm. This work of Nestor Muller and Charlie Bryan, my former mentor, and what he showed was that in preterm infants, if there was no distortion of the rib cage, all right, this was the power spectrum that you got, all right? If there was distortion, i.e. REM sleep, basically the low frequency went up and the high frequency came down. So they're showing that distortion of the rib cage, or REM sleep in and of itself, was associated with fatigue of the diaphragm. What he plotted here is the high-low frequency against distortion, and these were arbitrary units, but it was the amount that the rib cage distorted. And obviously, the more distortion there was, again in REM sleep, the more fatigue occurred. That is, the more the high-low ratio fell. So distortion of the rib cage, inward distortion of the rib cage, as evidenced by absent intercostal muscle tone or synchronous contraction, was associated with fatigue of the diaphragm. Here's an example where there was an infant who was on CPAP, taken off CPAP, and you can see that the high-low ratio fell, and this infant on clinical grounds had to be put back on CPAP. The physicians did not have access to this information at the time of the study. But this showed a baby who was doing well on CPAP, had to come off, or came off, in an attempt to wean. High-low ratio fell, that is diaphragm fatigue, and had to return to CPAP. So infants have decreased diaphragm strength and endurance, which can predispose to diaphragm fatigue. REM sleep increases work of breathing due to ribcage instability, and this can precipitate respiratory failure in some infants. Let's talk about the upper airway during sleep. So again, we talked about this. Any neurologic process, sensory input, CNS activity, motor output, these connections are greatest or most robust while awake, decrease slightly during non-REM sleep, and decrease significantly during REM sleep. And that's shown again here. So now we're talking about the upper airway. When the respiratory center sends a message to the phrenic nerve, causing diaphragm contraction, it also sends synchronous messages to muscles in the upper airway to contract and open, keep the upper airway open. In non-REM sleep, this robustness of these signals are not quite so great. So there is a chance that upper airway tone here will be somewhat decreased. And certainly people have heard people snore. Snoring is something that occurs during sleep when upper airway skeletal muscle tone is somewhat decreased. And remember that during REM sleep, the robustness of these signals are decreased considerably. There's in fact very little upper airway skeletal muscle tone, so one might suspect an increase in obstruction. So remember, we talked about apnea. Central apneas won't breathe. There is no diaphragm contraction or respiratory effort. Obstructive apnea can't breathe. There is diaphragm activity, diaphragm contraction, and this, however, is associated with inward distortion of the rib cage, as shown here, and absent flow at the upper airway. So here's the upper airway, and basically the situation is the tongue here can fall back. Remember, you're drawing a negative pressure down here. So you can suck the tongue back, you can suck tissues together that cause obstruction. So the upper airway is one structure that serves several functions: breathing, swallowing, and speech. Unfortunately, because one structure tries to do all of these things, it does not do all of them well. Breathing would be best served by a rigid tube. Swallowing requires strong, flexible muscles. Speech requires intricate movements. Previously, we've been talking about intrapulmonary airway obstruction, and you'll recall that the airways inside the lung during inspiration are subjected to negative pressure, which open them, and it's during exhalation that pressure outside the airway may be decreased. So intrapulmonary airway obstruction is primarily an expiratory problem. In contrast, extrapulmonary airway obstruction is an inspiratory problem. So here we have an obstruction. We need to overcome it by generating a hugely negative intrathoracic pressure. This causes the pressure inside the airway to be less than the pressure outside. So this causes obstruction during inspiration. During exhalation, we're actually drawing or generating a positive pressure, which, if anything, dilates the airway prior to the obstruction, so that extrapulmonary airway obstruction, defined as outside the chest cavity, okay, is an inspiratory problem, not an expiratory problem. So we hear stridor, for example, in extrapulmonary airway obstruction during inspiration. We hear wheezing during exhalation in intrapulmonary airway obstruction. So we're now going to talk about extrapulmonary airway obstruction. The upper airway is a so-called Starling resistance. So we have a fairly rigid tube in the nose, we have a fairly rigid tube in the trachea, and we have an elastic tube, if you will, in the pharynx, all right? So that this is a tube where the pressure, the patency of this tube is going to depend on pressure inside the tube versus outside the tube. So the P crit is the pressure where upper airways collapse. It's measured as the pressure difference across the upper airway. A more negative P crit, the less likely an airway is to collapse. That is, pressure can be negative inside the airway, it still manages to stay open. A positive P crit indicates a very collapsible airway. To give two examples, a bell jar here, you might remember from high school science or physics, one can generate a complete vacuum in here, and yet this will not collapse. So that is a negative peak grit, resistant to collapse. A positive peak grit would be like this fire hose here, which is collapsed at rest. So a normal child has an upper airway resistance to collapse and therefore relatively negative peak grit. This obese adult may have an upper airway that's collapsed at rest, and he would have a positive peak grit. So these are data from Carol Marcus, and this shows inspiratory flow rate at nasal pressures from positive 10 to minus 30. And what you can see here is that even if you have a pretty negative intranasal pressure, flow is not decreased substantially. However, this is a situation of a child with obstructive sleep apnea, and you can see that here. If intranasal pressure gets to zero, flow becomes zero. That is, you're not able to generate any flow. So this is a child with obstructive sleep apnea where peak grit at zero is associated with no flow. You need a positive peak grit, that has positive pressure in the upper airway, in order to generate inspiratory flow. So what keeps the airway open? It's basically a balance, and it's a balance between upper airway size, upper airway skeletal muscle tone, and inspiratory force. Things that open up the airway are bigger airways, increased upper airway skeletal muscle tone, and a decrease in inspiratory force. Remember that inspiratory force is generating negative pressure, which tends to collapse the airway. Conversely, what tends to close the upper airway is a smaller airway, decreased skeletal muscle tone, or an increased inspiratory force. So these things all will tend to close the upper airway. Negative inspiratory pressure can collapse the upper airway, and it's counteracted by a large size and/or increased upper airway skeletal muscle tone. Upper airway skeletal muscle tone is inhibited during sleep, especially during REM sleep, and therefore obstructive sleep apneas can and do occur. Let's talk about the upper airway during positive pressure ventilation while asleep. So here the situation is a little bit different. And these are data that were actually obtained with Irene Gilgoff, who was a rehab physician at Rancho Los Amigos National Rehabilitation Center. And what was noticed, this is a center that's well known for treatment of spinal cord injury and neuromuscular patients. Patients with high spinal cord injury, C1, C2, above where the diaphragm comes off at C3, 4, 5, so they were apneic, all right? And they were on mechanical assisted ventilation. And what was noted was that during sleep, these patients often became apneic, even though they were in positive pressure ventilation during sleep. Ventilator-dependent high spinal cord injury patients had hypoventilation or apnea during sleep. The hypoventilation went away when a cuff tracheostomy was used. So this proved that it was due to variable leak around the tracheostomy. Technique called pressure plateau ventilation compensated for variable leaks and maintained gas exchange, and therefore this hypoventilation went away. This hypoventilation occurred, however, during REM sleep. Right? So the problem is here for chronic ventilator patients, we're going to use an uncuffed tracheostomy tube. So you can have a leak around the tracheostomy tube. It does not all go to inflate the lungs, but some goes around the trach. Here's what happens. In upper airway skeletal muscle tone, it's maintained more or less during non-REM sleep. So this means that when you introduced air through a tracheostomy here, it's going to go down to the lungs to cause inflation in non-REM sleep. In REM sleep, however, all right, you have a basically relaxation of upper airway skeletal muscle tone. So now the resistance in the upper airway is less than the resistance in the lung, and therefore air is actually going to escape around the tracheostomy out through the upper airway, which has decreased resistance. So during positive pressure ventilation, airway pressure is positive during inspiration. REM sleep decreases upper airway skeletal muscle tone, which decreases upper airway resistance. So more air escapes through the upper airway during REM than non-REM, and this may result in hypoxia and/or hypercapnia during REM sleep. All right, so what have we learned about the effects of sleep on breathing? Hypoxia can occur in normal infants during sleep. Hypoxia does occur in BPD babies during sleep and feeding, though it may not be obvious. BPD babies do not respond well to hypoxia, often having apnea, bradycardia, and even needing bag-to-mask resuscitation. The chest wall is highly compliant in infants, and it can distort inward during inspiration. This can cause diaphragm fatigue. Upper airway closure during sleep is caused by increased inspiratory force, decreased airway size, or decreased upper airway skeletal muscle tone. REM sleep decreased upper skeletal muscle tone even further, and obstructive sleep apnea occurs. During REM sleep, positive pressure ventilation is less effective. Next time, we will discuss the effects of sleep on breathing, part 3. Thanks again to our director-producer, Dr. LeWinter, and thank you again for joining me for the great adventure, pediatric pulmonary physiology.